Hi.
Hi. Welcome.
Thank you so much.
First, I will introduce you to the audience.
Yes.
Elias Eriksson, İsveç'te Göteborg Üniversitesi'nde farmakoloji profesörü ve tıp doktoru kendisi. Özellikle nöropsikofarmakoloji alanında çalışmakta ve serotonin geri alım inhibitörlerinin etkisi ve klinik etkileri üzerine yoğun araştırmaları var. Son yıllarda da Parkinson üzerinde de çalışmakta. Kendisi 2014 yılından bu yana CMP'nin sekreterliğini yapmakta. Bugün bize çok ilginç bir konuşması olacak. Placebo, serotonin geri alım inhibitörleri placebo'dan daha mı iyi? Bununla ilgili bir sunum yapacak bize. Okay, Elias, it's your turn. Thank you.
Thank you so much, and I would of course like to thank the organizer for inviting me to give this presentation. It would have been even more nice to be with you in person, but I also regard it as a privilege to have this possibility to share my view on the antidepressant drugs. And I first would like to try to share my slides, and I hope that you can now see them. Is it okay? You see them? Yeah. Sorry for that. I shall start with the first one, not with the last one. Okay, so I assume that you can see this slide now, and the topic of this presentation will be are the SSRIs effective for the treatment of depression, and the bottom line will be yes, they are. It might seem strange to address this question many decades after these drugs have been introduced and used a lot, but there is of course a reason why this debate is important, and I will come to that shortly. These are my disclosures. I have not had too much connections with the pharma companies in recent years, but some honoraria from Lundbeck, Servier, and Janssen regarding mainly lectures and advisory boards. Also of note is that all antidepressants discussed in this presentation are since long off patent. Sometimes you get the impression from those criticizing the SSRIs that it is still the machinations from the big pharma that make people take these drugs, but unfortunately I would say these compounds are no longer of any interest for the big pharma because they are very cheap and have, as I said, lost their patent long time ago. So someone else will have to defend them. Sorry for that. This is the starting point for this discussion. On the one hand, a pharmacological approach to treat depression is endorsed by authorities throughout the world. In many countries, 7 to 10% of the population are currently on an antidepressant. So this is obviously a very established treatment. On the other hand, based mainly on post hoc meta-analysis of drug company-sponsored controlled drug trials, influential researchers and also other debaters, such as journalists, claim these drugs to be totally devoid of beneficial effects and also harmful. And then I will give a few examples of this shortly. But this is, of course, a very unsettling situation. On the one hand, patients are being prescribed these drugs. On the other hand, they read in the newspapers that they are totally ineffective and harmful. So my conclusion is that we must address this criticism seriously. If antidepressants are indeed ineffective, they should no longer be used. But if the questioning of the antidepressants, on the other hand, is scientifically unfounded, it must be rebutted so that patients are not discouraged from using an effective treatment that might even be life-saving. This is just one example of the critics. This is Peter Goetze, who was one of the founder of the Cochrane Institute, professor in Copenhagen. He has said stuff like psychiatric drugs are doing us more harm than good, and throw away the antidepressants urges leading scientists. You can read in the Telegraph. And he has also written this book. It looks like a book from the Scientologist, but it is indeed written by this professor Peter Goetze, Deadly Psychiatry and Organized Denial. Then we have a person, I missed this one. First we have another critic, Jonna Moncrief from UK. She has written, for example, a book called The Myth of the Chemical Cure, and also she wrote a paper with this quite telling heading, Are antidepressants as effective as claimed? No, they are not effective at all. She's psychiatry in London. And then we have the guy who has made the biggest splash in this debate, Irving Kirsch, who is professor from Harvard and also in UK. And he wrote, it was now quite long ago, this meta-analysis, that kind of meta-analysis that I mentioned. Meta-analysis on trial level, I should say. He did not analyze data from individual subjects, and I will come back to why that is unfortunate, but this is on trial level. And what he did in this study and then elaborated in this book that you see, The Emperor's New Drugs, Exploding the Antidepressant Myth. What he did here is to go back to the studies made by the drug companies, conduct post hoc analysis, how was indeed in fact the outcome, and then he came to the conclusion that these drugs are not effective. They might be somewhat effective for the most severely depressed patients, he said, but that superiority over placebo was mainly due to their side effects, causing the patients to understand that they had received active treatment, and therefore they had a larger placebo effect, a larger expectancy of improvement. So he denies that antidepressants have any pharmacological antidepressant effect at all, and that they might seem somewhat effective in very severe cases, but that is then just related to the side effects. This has been very widely disseminated in lay media throughout the world. These are just some examples. The US magazine Newsweek, antidepressants don't work, it says. And I could show you a lot of similar headlines from papers all around the world. My Turkish is not perfect, but I assume this is a Turkish translation of his book. So it has, obviously this message has reached also your country. He appeared in 60 Minutes in US television, and there they also interviewed a spokesperson from NICE, that is in UK, the authority, one could say, analyzing treatment effects and issuing guidelines for health care professionals. And this spokesperson, it says, first the speaker in this program says, it's so modest, and it's here referred to the antidepressant effect of antidepressants. It's so modest that in Great Britain, the National Health Service decided to dramatically revamp the way these drugs are prescribed. It did so after commissioning its own review of clinical trials. And then Tim Kendall is a psychiatrist and a spokesperson for NICE and NHS. We came to the conclusion that for mild to moderate depression, these drugs probably weren't worth having. The interviewer says, at all, not really, says Kendall. So this debate has clearly impacted also authorities in different countries around the world, which make it even more important to address these questions. This is not just a debate among Scientologists and among pharma critics in the media, it's also something that has impacted the authorities. Also in Sweden, for example, these authorities stated that for moderate depression, internet CBT was probably as good as antidepressant, and this was at the stage where the documentation, the evidence for internet CBT was indeed very poor, mostly related compared to waiting list and so. There has been a clear-cut reevaluation of the drugs also among authorities. However, this kind of meta-analysis that have had such a great impact, including the one by Irving Kirsch, but also other, they have certain methodological problems that have seldom been addressed in this debate. And one is that they are, as I said, conducted on trial rather than patient level. They have got the mean data from treated groups and analyzed that, but they have not received data from patients. And it's quite obvious that at least some of the issues at stake here could only effectively be addressed on patient level. For example, when Kirsch says that antidepressants are only effective in severe depression, he has studied the outcome of studies where the mean severity has been high as compared to the outcome in studies where the mean severity has been low. Needless to say, it's much more effective to study on an individual basis in each study. Patients with severe depression at baseline, does she or he respond better or worse to the treatment? Likewise, when Kirsch wants to convince us that side effects are the reason for antidepressants to sometimes beat placebo, then he refers to a study examining this also on group level. So in some trials, the patients had a lot of side effects, and there they had a relatively good mean outcome. In another study, there were much less of side effects and a worse outcome. Again, this is of course much more effectively studied on patient level. Did this patient display side effects, and did this patient respond to treatment? Then many of these authors have argued that there is no difference in dose between doses in terms of efficacy. There is just a flat dose response curve for the SSRIs, and therefore in many meta-analyses all doses that have been tried in clinical studies have been included, and that is also very low doses. And if you really would like to see how effective is a certain drug, you should of course only study the optimal doses, and therefore if there is a dose response, which they deny, but if there is a dose response, it is unfortunate that one has included what might be suboptimal doses. I will come back to this. Also, often, as in this study by Kirsch, they have lumped together drugs from totally different pharmacological classes, and that is also unfortunate. If you, for example, you are interested in hypertension and wants to explore in meta-analysis if a angiotensin receptor blocker is effective for hypertension, then you wouldn't also in the same analysis include patients on an calcium channel blocker or a beta blocker or something else. So it's quite natural that when you study the effect of drugs, you should study one mechanism at a time, but this has not been the case. And for example, in this very, very famous and very much cited meta-analysis by Irving Kirsch, a lot of the patients come from studies with nefazodone. I don't know if that is available in Turkey. I think it has been withdrawn all over the world because of side effects. But nefazodone is also not an SSRI. It has had a very weak effect on the serotonin uptake and was mainly a receptor antagonist. And I believe nefazodone had less efficacy than other drugs. So it's a bit unfortunate to include nefazodone in a study mainly dealing with SSRIs and SNRIs, just as an example. Also, and this is probably the major problem with these studies, is that they have assessed the effect using a questionable measure of depression severity, and that is the sum score of the 17 items of the Hamilton Depression Rating Scale. It was very good when excellent work by Max Hamilton when he once introduced this scale in the 50s, because a long time ago, because then we had no scales to address depression severity. So that was good, but it was, I don't think Max Hamilton ever contemplated that the same scale and the sum rating of the items of this scale should be used many decades later to assess the efficacy of modern antidepressants. And it's obvious that this scale, this measure, is associated with problems. One could defend the meta-analysis people, such as Kirsch and others, using this as a measure of severity by the fact that this is also what the drug companies have used as a measure of severity in their trials. And the reason why the drug companies have used it is that it was used in the very first study on the tricyclic antidepressants in the 60s. And therefore, the companies have known that the FDA and other authorities would accept this kind of measure, and therefore the companies have not dared to change it to something new, because they have known that this is regarded as okay by the authorities. But it has been no secret that this is a very insensitive measure of change in depression studies. One problem is that it's multidimensional, so it measures different domains, and it could then be that you are very much improved in one important domain, but you are less improved in a less important domain, and then the effect on the important domain is masked by effects on other domain, or lack of effects on other domains. Then many of the items in this 17 item scale are by depressed patients rated 0 at baseline. And then, of course, since you cannot get any better than 0 in terms of symptom severity, these items would in these patients not contribute anything in measuring improvement, just increasing variability and then reducing the chance of getting a significant difference between active drug and placebo. And it's also true for this scale that many items may be present also in recovered patients, and that also, of course, lead to an enhanced variability and less sensitivity of the scale. For example, back pain is a common symptom in many non-depressed subjects, and even if your depression is into complete remission, you may still have back pain, and there you have some points on this scale. You may have sleeping problems also if you are not depressed, and so on and so forth. So it has in fact been shown that in a normal population of non-depressed subjects, they don't rate 0 on this scale, but they usually have some symptoms in spite of the fact that they are not depressed. And what has been particularly important in studies with SSRIs is that certain common SSRI side effects are rated as symptoms in this scale. These are problems that could, of course, also be symptoms of depression, such as gastrointestinal dysfunction, reduced libido, weight change, mostly weight reduction. But they may also appear in an SSRI-treated patient that is totally free from depression, because it could be side effects of the treatment that I will show you shortly, that they seem to have impacted the outcome here to a great extent. When this scale was first developed, it was used in the old tricyclic studies, and generally, as you all know, tricyclics have much more side effects than the SSRIs, and more severe side effects with dry mouth and so on. But in fact, this scale does not pick up very much tricyclic side effects, but it definitely picks up SSRI side effects, which has been unfortunate. Also, I think in the very beginning, when they started to use this scale in clinical trials, the investigators were informed that they should, if they regarded a certain symptom as a side effect, they should not count it, but that has been forgotten since many decades. So today, the SSRI side effects certainly contaminate the scale, and hence reduces the chance of detecting an improvement. that it's certainly not our original idea that this scale has a lot of problems. It has been shown, for example, or discussed in this paper already 2004 by Bagby co-workers. The Hamilton Depression Rating Scale has a gold standard become a lead weight, and the conclusions evidence suggests that the Hamilton Depression Scale is psychometrical and conceptually flawed. There was also a Danish psychiatrist called Per Beck who showed that if you instead just analyzed 6 core items, core symptoms of depression from the Hamilton scale, then you could have a much more sensitive measure of improvement in studies. And I will come back to that Beck scale shortly. Then I think it's not unfair to say that a consistent and unfortunate, there have been an consistent and unfortunate anti-drug bias in the interpretation of data in many, not all, but in many of these meta-analyses. The authors seldom discuss the problem with the analysis, seldom the kind of methodological problems, and they seem to often have a very strong anti-pharma stance, which is unfortunate. It's often in these days said that if an author have had any connection with the big pharma, that is a bias, but I think on the other hand, we do have an anti-drug bias that is also a problem in the scientific debate. So, which are the arguments from these guys questioning the antidepressant? Well, here are, I would say, the most often heard arguments. First, 50% of placebo-controlled trials fail to show superiority of the active substance. Many studies have been negative. Second, the SSRIs do not display a dose-response relationship and hence cannot exert a true pharmacological effect. I mentioned that briefly recently. Third, the beneficial effect of SSRIs, if there is one, is too small to be clinically relevant. There may be a statistical difference, significant difference, but that is too small to be clinically of any importance. Also, the beneficial effect of SSRIs, if there is one, is present only in patients with very severe depression. I mentioned that. Next, the superiority of SSRIs over placebo found in some clinical trials is merely the result of side effects breaking the blind. I mentioned that as well. And also, it is often argued that while not exerting any beneficial effect, the SSRIs are suicide-provoking, so a subject not suicidal from start may become suicidal when taking an SSRI. And I will now, in this lecture, discuss if the questioning of the SSRIs regarding these different issues, is it supported by available data or not? For this project, we have also conducted meta-analysis, but we have done it in a different way as compared to other workers. Firstly, all the meta-analysis that you will see in this presentation have been on the meta level, on the patient level, sorry, on the patient level. This is on the subject level. This is sometimes called mega-analysis, when you don't look on mean values from groups, but on the individuals. And of course, we have then had to obtain patient-level data from the drug companies. I will come back to that shortly. But we did so after a lot of discussions, and now we have a big database with patient-level data. Also, we believe, unlike Kirsch and others, that only drugs from the same pharmacological class should be included in each analysis. We have, of course, included all relevant trials, both the positive ones showing a difference that have often been published in scientific journals, but also the negative trials, those showing no difference and that have not been included and not been published in journals. Otherwise, if you don't include all, you will be accused of cherry picking, and we certainly have avoided that criticism meticulously by including all trials. We have addressed the issue of dose. We have not taken for granted that all doses are equally effective, but we have studied that. We have not just used the sum score of the Hamilton scale as measure of outcome, but also looked on effects on individual symptoms. The SSRIs that we have studied, that I will show data from today, are citalopram, sertraline, and paroxetine. Approximately 3,000 individuals in our database. We have also studied an SNRI, that is duloxetine, and there we have about 4,500 subjects in our database. In most, but not all analyses, we have pooled data, so we have pooled all subjects on an SSRI and all subjects on placebo and compared these groups. Sometimes we have analyzed also individual studies, but mostly we have used pooled data sets. So when we started this, we had to then have patient level data. Today, and this is 10 years later, this is not too difficult to obtain because the companies have reluctantly realized that they must show greater transparency. So now you can usually request patient level data from different websites. But that was not the case 10 years ago. So when we approached these 4 companies to get the first all data on the first SSRI trials from the first generation SSRIs, they were at first reluctant to share this data because that was not what they usually did. But after some discussions, we managed to get data from GlaxoSmithKline on paroxetine, Pfizer on sertraline, and Lundbeck on citalopram. Lilly would have liked to provide us with data. They said, and I believe them, but they couldn't do that because the old Prozac studies were not in an electronic format, so they couldn't do that. But they have, on the other hand, provided us with duloxetine data, so we have received data also from Lilly. I would just like to make one other point before going forward with the results. While the questioning of antidepressants has often been focused on the most commonly prescribed of these, the SSRIs, the critics generally portray all antidepressants as useless. They don't say that some are better and some are worse. They say that all of them are equally bad. It's like an anti-vaxxer regarding vaccines. They usually believe all vaccines are bad, and it's the same here, that those being critical of the antidepressants usually argue that all antidepressants are useless, and also that electroconvulsive treatment is useless. In this presentation, I will only include data regarding SSRIs and to some extent SNRIs, but it should be noted that there are probably other antidepressants that are even more effective. I'm not claiming that SSRIs are the most effective. I'm claiming that they are better than placebo, but there are definitely antidepressants that are more effective. For example, I was quite convinced by these old studies from a Danish university group of antidepressants where they compared the new drugs that came at that time in these 2 reports, paroxetine and citalopram, and showed that the good old clomipramine and afranil was in fact superior to these drugs for the treatment of in patients with depression. They didn't have any placebo groups here, but they saw this kind of difference. And if you have read the meta-analysis by Cipriano and co-workers in Lancet that has obviously a great impact on the field, what they find is that the amitriptyline, another old tricyclic, might be the most effective of all antidepressants. That is quite a large difference. I think partly this could be an artifact because amitriptyline is an antihistamine also, and it's very sedative, and since there are 3 sleep items in the Hamilton scale, they might get some extra points there without being better in terms of a pure antidepressant effect. But I also think we have looked into some of these studies, and we are analyzing that right now, and I won't show you the data yet, but it seems that amitriptyline might be in fact more effective also in terms of reduction in depressed mood, for example. So this is just to remind you that the SSRIs are probably not the most effective antidepressant. And I certainly hope that we in the future will be able to develop antidepressants that are even more effective. Okay, so I would like to address briefly, rapidly, all these different arguments against the drugs. And the first of them, 50% of the trials failed to show superiority. This has been reported in some by others in the scientific literature in 2003, Melander and other Swedish authors that are all working on the Swedish Medical Product Agency, the corresponding to the EMA or FDA, but in Sweden, they noted that it was a bias in the publication strategy, so that there were indeed a lot of negative studies that never entered the scientific journals, and the same was reported by Turner and co-workers in New England Journal of Medicine some years later. And Kirsch has called this phenomenon the dirty little secret of psychopharmacology, that in fact half of the studies aimed to show superiority of the active drug over placebo have failed to do so. I don't know if it has been a secret. I think many of us have been aware of this for a long time, but this for Kirsch this was obviously something quite exciting to realize. Okay, so in this report, I will just see that it's the right slide. Yeah. In this report, we have not pooled data, but we have analyzed all comparisons undertaken by the drug companies with paroxetine versus placebo, citalopram versus placebo, or sertraline versus placebo. And when fluoxetine has served as an active comparator, we have included fluoxetine data as well. And we have only excluded so small trials where for statistical reasons it would have been difficult to obtain a difference. So all comparisons of a reasonable size we have included in this. And this is a messy slide and a boring slide, and I will just mention the highlights here. If we use the conventional measure, the measure used by the drug companies and also the measure used by Irving Kirsch in his meta-analysis and by other authors conducting meta-analysis, only 14 out of 32 comparisons revealed a difference. So that is not very good. SSRI was able to beat placebo only in 14 out of 32 comparisons. However, if we skipped this parameter, the sum score with its problems, and instead looked on just one symptom, the first symptom of the list, the symptom that almost all patients display at baseline, that is depressed mood, what will then happen? Of course, I don't claim that depressed mood is the only important symptom in depression, and I certainly realize that it's important also to treat other symptoms. But I think it's fair to say that a drug that reduces depressed mood cannot be all that bad, and a drug that fails to reduce depressed mood is not a good antidepressant. So we found it defendable to just look at depressed mood here. And what you can see in 29 out of 32 comparisons, 91%, we did see a superiority of SSRI or placebo. It was a strikingly consistent effect, very few negative trials. And here we have included also low-dose trials and all kind of trials, just if they had sufficient size. So we would argue that there are in fact not a lot of negative trials. You can detect an antidepressant signal in most trials ever undertaken, in spite of the fact that these trials are marred by other problems that could reduce the chance of detecting a difference. So what is the reason for this? Well, here you have the effect sizes for the different measures, and if you here you have the 17-item effect size, that is 0.27, not too good, one could say. And when we look on depressed mood, we have an effect size of 0.4. So why is it so much better than the effect size for the Hamilton? Well, it can to a great extent be explained by the SSRI side effects. Here you can see that for the 3 sleep items, SSRIs display a very poor effect size, especially early and middle insomnia, less so for the typical depression symptom of early morning awakening, but for in early and middle insomnia, we have a very low effect size for the SSRIs, which is what you should have expected, since SSRI may cause disturbed sleep as a side effect. Also, we have a negative effect size that is, of course, not significant, and it's around 0 for gastrointestinal symptoms. And this is also a typical SSRI side effect. Sexual side effects, reduced libido, again, if anything, a negative effect size, but more or less no effect whatsoever. Again, a typical SSRI symptom impacting the scale. And also loss of weight. These drugs, especially early on in treatment, but sometimes throughout in a trial, reduce appetite. So you usually have a negative impact on weight in SSRI-treated groups. And this is not regarded as a pro in this context, but as a con. This will give some extra points on the Hamilton scale. That has nothing to do with if you are depressed or not. So we would suggest, this is this paper, it was published in 2015 in Molecular Psychiatry, consistent superiority of selective serotonin uptake inhibitors over placebo in reducing depressed mood. And Fredrik Hieronymus, who was a PhD student, was the first author, and a very brilliant guy who has made most of these analyses in this paper. We suggested in this paper that it was the side effects that impacted the scale, and that was the explanation why the sum score of the 17 items performed so poorly. But we also wanted to show this, and we have done that in a more recent paper. In this study, we didn't analyze side effect reporting at all, but we did that in a duloxetine, a number of all relevant duloxetine trial, duloxetine versus placebo. And here you can see that the overall side effect severity reported by the patient impacted the end score of the Hamilton scale at end point. And this is for the non-core items of the scale. You find these items mostly not among the core symptoms, but among other symptoms. And then you can see the more side effects you have, you report to the doctor, the worse you perform on the Hamilton scale. And we also, of course, have looked if there is a correspondence, one typical side effects versus that item, and it fits nicely. Those reporting sleep-related side effects, they also have more rating of sleep symptoms on the Hamilton. Those with reporting gastrointestinal side effects also have more rating on that item in the Hamilton. And that the gastrointestinal symptoms also impact the somatic anxiety item. And those reporting sexual side effects also have more side effects, more symptom rating on the scale. So what we try to show in this paper from this year in Translational Psychiatry is that the more side effects you have, the less improvement you will show on the Hamilton scale, regardless of if you are completely recovered from your depression or not. So we don't buy this argument. We do think that in fact the beneficial effect of SSRIs on such a key symptoms as depressed mood is quite consistent. There are not many totally negative studies. Then what about this with dose response? Do we have a dose response for the SSRIs or not? Kirsch writes this in his book: the therapeutic effects of antidepressants are not dose dependent. The difficulty of finding dose-related therapeutic effects of antidepressants is yet another reason for suspecting that those effects may be independent of their chemical action. And this is Marcia Engel, and she is certainly a key opinion leader in the medical field. She was for many years the editor-in-chief of the most prestigious medical journal of all of them, New England Journal of Medicine. And she had in New York Review of Books a review of Kirsch and others' books. the crazy state of psychiatry, she says, and she is totally convinced by all the arguments by these authors. She's very enthusiastic, and she, for example, says that Kirsch reported a number of other odd findings in clinical trials of antidepressants, including the fact that there is no dose-response curve. That is, high doses work no better than low ones, which is extremely unlikely for a truly effective drug. I'm a pharmacologist, and I could agree that this would be unlikely for a truly effective drug. One should see some kind of dose-response association, and in fact we did. We have just analyzed the fixed dose trials, not the flexible dose trials, and we do find that there is a dose-response association for citalopram, paroxetine, and sertraline, in the sense that to get a maximum antidepressant effect, you should give a dose of 40 milligram of citalopram. That should correspond to 20 milligram of escitalopram, since that is the active enantiomer of racemate. We didn't include escitalopram in this analysis, but I think one could extrapolate that you would need 20 milligram of escitalopram. We show that you need 100 milligram of sertraline to have an optimal effect, and 20 milligram of paroxetine. When we then pool the different SSRIs in suboptimal dose and optimal dose, we do find, this is with the Hamilton 17 scale to the left, we do find a significant, sorry again, I'm shifting the slides too rapidly here, or my computer does that. This is low versus high dose, and we have a significant difference at end. That is the very definition of a dose-response association. So it is not true when Kirsch and others say that there is no dose-response association. It is. And it's even more clear when we see a more clear separation when we instead look on depressed mood as a measure. Again, a significant difference between low and high dose. Another interesting side finding here is usually it is said that antidepressants exert no effect before 2 weeks have elapsed, and it certainly seems so when we use a Hamilton scale. After 1 week, the three groups are almost inseparable. But when we look on depressed mood, on the other hand, they are significantly different. So the reason why we don't see this with the conventional measure is probably that these drugs cause initial side effects such as nausea and so on that impact the rating. But in fact, when it comes to depressed mood, we do have some effect, not an impressive effect of course, but some effect separation already after 1 week of treatment. And why is this important? Well, it could shed some light on the mechanism of action of these drugs. Sometimes, for example, these days it argued that they act by forming new nerve cells, but that would not be compatible with this observation, I could say, because forming a new nerve cell would take longer time than a week, if at all possible. So in that regard, this finding is of some importance, that the groups here start to separate already after 1 week. And here you can see that there is a significant difference between placebo and low dose and placebo and high dose. This early we don't see a difference between low and high dose. That comes later on, probably because you are slowly escalating the dose also in the high dose groups. Okay, so this was published in 2016 in Translational Psychiatry, again with Fredrik Hieronymus as first author. Okay, I could also argue that Furukawa and co-workers have published in Lancet Psychiatry an assessment of what is optimal doses of SSRIs, venlafaxine and mirtazapine, and they came to very much the same conclusions that we do regarding citalopram, paroxetine, and sertraline. They also had data on fluoxetine that we didn't have, suggesting that about 20 milligrams would be an optimal dose of fluoxetine. Okay, then a separate question that has nothing to do with the critics of the antidepressant, but what we believe was interesting to explore is, given these dose-response associations, are depressed subjects given a maximum dose? And I cannot, of course, say anything about the prescription habits in Turkey. So this is in Sweden. And here I can clearly say that no, they don't. This is above 65 years of age and below 65 years of age. And these are the doses prescribed by general practitioners. And as you can see, red here means that during a depressive episode, the patient has never been offered the optimal dose of the drug. And that means the patient has not had the chance to test it and then again go back to a lower dose because of side effects or so. They have never ever tested the optimal dose. And that is a majority this is case for a majority of patients ordinated citalopram, escitalopram, or sertraline, both below and above 65 years of age, but not for fluoxetine and paroxetine. Here, almost everyone obtains the optimal dose. And one obvious reason for this, as in Swedish dosing recommendation, the starting dose for paroxetine and fluoxetine is also the optimal dose, 20 milligram per day. So therefore, almost everyone gets that dose. With respect to citalopram, escitalopram, and sertraline, there is a lower recommended starting dose, and it seems as if the general practitioners are not very inclined to increase the dose above the starting dose. They seem to have somehow misunderstood the dosing recommendation that it would be okay to stay on this dose. And this should theoretically at least lead to that the patient do not get the benefit from these drugs that they could have achieved if given a higher dose. Also, we have looked, could it be that the doctors know that patients do not tolerate the optimal doses because of side effects? Well, that does not seem to be the case, because patients that have been testing the optimal dose do not stop treatment or do not reduce dose more often than those have not given the optimal dose. It seems that if a patient receives an optimal dose, he or she will continue with that dose. But most of the patients never have the chance of testing the optimal dose. For those above the age of 65, this could for citalopram and escitalopram partly be explained by recommendations, because due to the possible cardiac effects on the heart, side effects on the heart, and the risk for arrhythmias, it is not recommended to give patients above this age the higher doses of citalopram, escitalopram. But this could not explain why patients are not giving optimal doses of sertraline, because there we have not that recommendation, and also not why patients below the age of 65 seldom obtains the optimal dose. Psychiatrists, are they more inclined to prescribe the optimal doses? Well, somewhat, but not that much. Also, patients that by definition have a difficult to treat depression or a severe depression, because otherwise they would never reach psychiatry. Also, these patients often do not ever test an optimal dose of the drug. Okay, but that was that was outside the line of this presentation. This has been published in Acta Psychiatrica Scandinavica in 2020. Low SSRI dosing clinical practice, a register-based longitudinal study. But it might well be that in your country higher doses are usually given. This is the case from Sweden. So, but to come back to this list, we do believe that SSRIs display a dose-response relationship, so we think this criticism can be rebutted. And on the contrary, one could say that the fact that they do display dose-response relationship could be taken as an argument that they do, in fact, display a pharmacological effect. Okay, then it's often stated that the beneficial effect of SSRIs, if there is one, is too small to be clinically relevant. Well, how can you measure the magnitude of differences between treatment groups in depression trials besides p-values? Well, you can look on the difference between the groups in mean symptom rating. You can look on differences between groups in response rates, and you can look on effect sizes. And I will briefly address all these aspects, because the critics have addressed all these three aspects. First, the difference between groups in mean symptom rating. This was a paper by Moncrieff and Kirsch, where they basically say that the background here is that the NICE in those days in UK suggested that to be clinically relevant, the difference between two treatment groups in a depression trial should be at least 3 points on the Hamilton sum scale. And what these authors argue in this paper is that such a difference is not clinically relevant. They say, in the current paper, we apply an empirical method that consists of comparing scores obtained on the Hamilton rating scale for depression and scores from the Clinical Global Impression Improvement Scale. This method reveals that the Hamilton difference of 3 points is undetectable by clinicians using the Clinical Global Impression Scale. A difference of 7 points on the Hamilton scale is required to correspond to a rating of minimal improvement on the Clinical Global Impression Scale. By these criteria, differences between the 3-point criterion between antidepressant and placebo in randomized controlled trials, including trials conducted with people diagnosed with very severe depression, are not detectable by clinicians and fall far short of levels consistent with clinically observable minimal levels of improvement. So they think that we have been much too liberal when it comes to what kind of difference should be required to regard an antidepressant as effective. So I would like to address this question. Is the 3-point difference in the Hamilton sum between active drug and placebo clinically irrelevant, as stated by Kirsch and others? And of course, there are two things one could say here. One thing is that, as I said, differences in the Hamilton sum score is misleading, e.g. because of side effects contaminating the scale. They not at all address this crucial aspect in this criticism. They still seem to believe that the Hamilton sum score fairly reflects the severity of depression, which is clearly not the case. But also, another point of view here is that a mean difference of 3 points between two treatment groups, of course, does not mean that all subjects improve this modestly, because in the actively treated group there may of course be both responders and non-responders, and non-responders may even rate higher at the end point because they have had some side effects impacting the scale. So it seems that Kirsch and others believe that all patients are improved by 3 points, and that only 3 points, and that is clinically relevant, when the truth, of course, is that the 3-point is a mean of improvement. Some subjects improving dramatically, and some subjects not improving at all. So, but if this is the case, then it should be a greater variability in the end scores for patients on active drug than on placebo, one could argue. And here are some studies questioning that. There is one study by Plöderl and Hengartner, and these are obvious, these are very harsh critics of the antidepressants, and they have analyzed this, and they claim, based on trial level meta-analysis, that the lack of increased treatment outcome variance that there is no higher variance in the actively treated group than in placebo group in randomized controlled trials. So they say that no or only very small subgroups of patients respond particularly well to antidepressants. They also say that hence the scope for personalized treatment with antidepressants seem to be limited. So they say that they don't see another distribution of points on the scale in actively treated patients as compared to placebo-treated patients, and therefore we can assume that all patients just improve by a very few points. Likewise, another group that certainly are not from the antidepressant camp, but they also came to the same conclusion. They also did a meta-analysis on trial level, and they also found no greater variability in those patients given active antidepressant versus those given placebo. They are much more careful in their conclusion. They say, although the study cannot rule out the possibility of treatment effect heterogeneity, it does not provide empirical support for personalizing antidepressant treatment based solely on total depression scores. So we studied this both on trial level and on individual level. And if we tested this on trial level, we also saw the same. We couldn't detect a difference between actively treated patients and placebo-treated with respect to the distribution of endpoints. But if we study this on patient level, we see a clear-cut such difference. Here you have from one typical study the distribution of patients given active treatment. Here you can see the responders with low endpoint scores, and here you can see the non-responders. This is with the Hamilton 17. And you can see that the placebo-treated patients much more like a normally distributed curve. And this was seen often, and when we fused all studies in our analysis, we did see a highly significant difference between placebo and antidepressants in terms of distribution. So we rebut the arguments from, for example, Plödel and Engart. It is indeed not the case that the distribution is similar, it is highly unsimilar. So we don't think that any of these arguments are very valid when it comes to questioning the 3-point difference. Now I think I go on the wrong direction here. No. Yeah, so this was published in this year in Acta Psychiatrica Scandinavica. Okay, then we have just for fun, and this is a bit complicated, we have just for fun tested, given some methodological problems here, is it possible to obtain very high differences between groups in mean symptom rating, symptom improvement, if you have a very good antidepressant, given that we have such an improvement in the placebo group, that we have large dropout rates, and that we have and that the mean Hamilton rating even in non-depressed subjects is above 0. So we have done some simulations here, and I certainly won't go into detail here because we haven't time for that. But what we have done is that we have taken actual data, real data from placebo patients. So these are real data in the placebo group, the green curves here. And then we have assumed that the very same patients, if they had been given active treatment, they would have improved 50% more than they did on placebo. And that is a considerable, robust improvement. So what would have happened if 60% of the patients had improved 50% more than they did on placebo? And even in that quite encouraging outcome, we would only have had a mean difference of 3. So we would be far below the cutoff suggested by Kirsch and Moncrief of 7. We would be around 3 if 60% of the subjects had performed at least 50% better than they did on placebo. And if all patients had displayed a 50% better improvement than they did on placebo, all patients, no non-responder, still we would just have had a mean difference of 5.5. That is below what Kirsch suggested as a cutoff for a minimal improvement. So obviously one must take these difficulties into consideration when addressing these aspects. What is obtainable given these problems of dropouts and placebo responses, spontaneous remission, and so on. For example, for a rapidly acting drug such as esketamine that you have all heard of, that has an acute antidepressant effect, it is certainly easier to get a clear-cut difference versus placebo because you don't have the problem with dropouts and you don't have the problem with spontaneous remission and so on. But with long-acting antidepressants, these are inevitable methodological problems. Then I would like to go to another measure of of improvement, and that is response. And as you know, it has often been a response to treatment has often been defined as a 50% reduction in symptomatology. And then Karsh and Moncrieff again here, this is another paper from these authors, they have here shown this figure that suggesting that we only have we have a 3-point difference for all subjects, that these are those treated with active treatment and these are those treated with placebo, and this is a very small difference, and still, since the cutoff is here at 50% at the median of the curve, then this would be highly statistically significant, but it would be meaningless from a clinical point of view. Here one could say, first of all, that the curve, as I showed you just recently, the curve doesn't look like this. There is not two bell-shaped curve that are shifted to the right for the drug curve. This has another shape with responders and non-responders. But also disregarding this, is it true that they claim that the drug companies have been smart enough to put the definition of response where it would be most likely to get a significant difference? So we tested, this is citalopram, paroxetine, and sertraline again. We tested what would happen if we define a response differently. So here you can have the entire distribution of various response definition, 40% or 60% or 80% or 50%. And as you can see, the lines here, this is a cumulative proportion of patients at end remaining symptoms at endpoint. These lines are parallel. So it doesn't matter where you put the response definition. It's not a big deal that it happens to be at 50%. We would have a similar outcome, similar difference if it was 70% or 25% or 80%. Where the lines differ, where they are not in parallel, it's here. The patients with the less symptoms and patients with most symptoms. There you have more symptoms with no symptoms, more patients with no symptoms on the active drug, and more patients with a lot of symptoms on placebo. And that is why you have the difference, not because you have a definition of response as 50%. And this is in fact more or less accepted now by translational psychiatry. It will turn up there shortly. And in the same paper we looked on response figures, and I don't think they are too bad. For example, 50% response with the Beck scale. These are the six key symptoms of depression. Only 44% of placebo patients display that, but 66% of SSRI patients. And with respect to a remission criterion for Hamilton 6, it's not good for any other drug, but it's at least twice as common for SSRIs and for placebo, 21% and 11%. So it's not too bad, also with the response aspect. Okay, finally, on this part of the lecture, I will talk about the effect size. What about the effect size of the effect of SSRI in depression? Generally, it is said that 0.2 is a low effect size, 0.5 is a medium effect size, 0.8 is a large effect size. And I would just come back to these curves. I showed this before. So you have seen this slide before. And this was, as you recall, when we had separated low dose from high dose. And let's see what happens with depressed mood. That is a more sensitive and, in our opinion, better measure for an antidepressant effect. And if we take away the low dose subjects, because those are suboptimal doses, when the difference between placebo and high dose has an effect size of 0.5. That is not too bad. It's quite a decent effect size. And this is a nice, for psychiatry, nice report by Stefan Leucht, where he compared effect sizes for drugs used in psychiatry as compared to drugs used in general medicine. And as you can see, psychiatry is not too bad. We are better off than many drugs with our drugs and many drugs in somatic medicine. And if one uses our way of measuring the effect size in depression, that is looking on depressed mood and only looking on optimal doses, it is placed somewhere here. A lot of drugs are worse, not least in somatic medicine. So the SSRIs come out quite decently in terms of effect sizes. Then one should realize that there are factors causing an artifactual reduction in the apparent effect size in depression trials that we have not been able to correct for in our analysis, as compared to, say, a study of hypertension, where you just measure blood pressure, a very distinct value in well-defined patients with hypertension, and that also no spontaneous remission, for example. And these are some of these problems. We have an outcome measure characterized by marked variability. That is true also for the depressed mood item or the Beck scale, not only the Hamilton scale, but also our measures are, of course, somewhat arbitrary as compared to measuring lipid levels or blood pressure. Then it's known that there is a poor compliance in depression trials, probably poorer than in, say, hypertension trials. It's also known, and this has been shown to influence the outcome, that it's a often artificially high rating at inclusion, because both doctors and patients want to include the patient, and to include the patient you have to reach a certain cutoff of the scale, and when you have reached that step and the patient is included, then at the next visit you haven't this incentive for somehow overrating the symptoms, and then the rating will decrease in both placebo and actively treated patients, which will make it more difficult to observe a difference. And then, of course, depression is a condition characterized by a spontaneous remission. You have the phenomenon of regression towards the mean. That will also mean that it will be more difficult to catch a difference, as compared to, for example, hypertension, when you don't have a spontaneous remission usually. And then it's also an obvious problem in recruiting genuinely depressed patients. This is a terrible disorder, and why would you elect to join a study when you instead can go to your closest GP to get an active drug? So probably it's to a great extent patients that have not responded to treatment that end up in the clinical trials. So they are from start to a great extent difficult to treat depressed patients. And also, since we have no proper blood test for depression, there's also a risk that we include patients that are not genuinely depressed, patients that are sad for other reasons than depression. This was nicely shown in this trial. It's bigger, better for depression trials. Here they had data from 4 trials where placebo had been compared with paroxetine, and it was 150 patients per group. 3 of these comparisons were positive, showing paroxetine better, 1 was negative. And then they excluded the 50 last recruited patients in each group of each trial. And that should, from a statistical point of view, make the p-values higher, because the more patients you have, the greater statistical power. But when they skipped the 50 last recruited patients, that generally rendered the p-values lower, and it turned the negative study into a positive one. So their conclusion is a hypothesized explanation for this finding included a depleted pool of depressed patients and the rush for patient recruitment at the end to meet completion deadline. I think this might have been an important factor in many depression trials, explaining when the outcome has not been as good as one had hoped for. So given these methodological problems, I think an effect size of 0.5 must be regarded as highly respectable for these drugs. Okay, I will now hurry on because I thought we should leave some questions, some time for question. But it has been argued that the beneficial effect, if there is one, is present only in patients with very severe depression. Some studies have suggested that there is a clear-cut association between baseline severity and response, so that only patients with high baseline severity do respond. For example, This one by Kurz that I mentioned before, but also one by Fourier and co-workers and by Kahn and co-workers. There has on the other hand been also studies not finding such an association by Fontolakis, for example, and by Gibbons and by Melander. So here is no consensus regarding is there an association between baseline severity or not. In this study that was on patient level and trial level, they did find such an association on trial level, but they did not find it on subject level. We did our own analysis here on subject level, and when we look on the Hamilton 17, we do in fact find some support for Kurz's stance. We do see an association between outcome and baseline severity. Here is the baseline scores, and here are the endpoint scores. And as you can see here, the separation between placebo and SSRIs is bigger at the end, seem to be dependent on severity. It's bigger here with higher severity than with lower baseline severity. To get the significance, we had to exclude some extreme values on both sides, very few. But if we excluded those that just disturbed the significance statistics, then we did get a significance in line with that described by Kurz, for example. However, importantly, when we looked on depressed mood, a key symptom of depression, the lines were parallel. Then we did not see a better effect in those with greater severity at baseline. Also, when we looked on the Beck subscale with only core symptoms of depression, the lines were parallel. But when we looked on the non-core symptoms, those not included in the Beck scale, we saw a marked difference. No difference between placebo and active drug in those with so-called non-severe depression, but marked difference in those with severe depression. The same shown in another way. Here you can see the reduction in the Hamilton 17, and this appears indeed somewhat bigger in the severe group to the right than in the mild group to the left. However, depressed mood, we have exactly the same reduction in symptoms in those with non-severe depression as in severe depression. With respect to the Hamilton 6, again, absolutely no difference between the non-severe and the severe. But with respect to the non-core symptoms, there we have no effect whatsoever in the non-severe group and a marked difference in the severe group. And why is this? Well, this explanation is a very simple statistical one. To be defined as severe, you have to have a lot of points on the Hamilton scale, and to have a lot of points, you must display also the core symptoms to some extent. With respect to the non-core symptoms, with respect to the core symptoms, severe and non-severe patients in our analysis do not differ very much. They all have depressed mood and anxiety and so on to the same extent. The difference to be defined as severe depression or defined as non-severe depression is if you have display the non-core symptoms or not. And therefore, since these patients do not have these symptoms to a great extent, they cannot be any better. But in this group, they can be better. So I won't go into detail here, but this just shows that for the core symptoms of depression, we have similar superiority, similar difference, but for the other symptoms, the non-severe depression performs more poorly. And here you can see also that with respect to baseline symptom rating, there is no major difference between those with non-severe depression and severe depression. They have about the same magnitude of their core symptoms, but marked differences when it comes to the non-core symptom. So we think that I think we can skip this slide. So we think that the effect of severity on outcome is not that important. If you are interested in reducing core symptoms of depression, then these drugs are just as useful for non-severe depression as for severe depression. So we strongly disagree with Tim Kendall when saying that for mild to moderate depression, these drugs probably weren't worth having. This was published in Lancet Psychiatry 2019. And now I will just very briefly address the issue of could it be the side effects that makes the SSRIs appear better than placebo in some studies. The idea here was from Kirsch that when you go into a study, you know that you are at risk of getting placebo. And then after a few days or weeks of treatment, you have some side effects, and then you realize that you have been allotted to the active treated group, and then you are happy for that, and you have a greater expectancy to get improved, so therefore you have a stronger placebo effect than you have if you don't feel any side effects. Kirsch has said it like this: rather than comparing placebo to drug, we have been comparing regular placebos to extra strength placebos. The belief that antidepressants can cure depression chemically is simply wrong. Is he right? No, he's not right. Here we have studied patients on paroxetine compared to placebo, and we have here separated those reporting adverse events, ever so mild, and persons not reporting side effects. And the important thing is here that we, between those given placebo and paroxetine patients without any side effects, there is still a marked and highly significant difference. So it cannot be that the side effects are responsible for the difference, because then we would have seen no difference between these two groups. You could argue that we have even better effect with those patients with adverse events, and that could of course be in support of Kirsch theory, but there are also many other explanations possible. It could be, for example, that here we have included all doses, so it could be that here you have patients with somewhat higher doses that both have more adverse events and a better effect for that reason. It could be pharmacokinetic differences, that some patients metabolize the drug less effectively, and then they have, for that reason, higher plasma levels and more side effects, and also a better effect. So there could be many reasons for this difference, but the important thing here is this difference, that also those without side effects perform better than drug patients on placebo. We did the same for citalopram, and again, the important difference is this one: those on placebo performed worse than those on citalopram without any adverse effect. In this analysis, those without adverse events performed somewhat better than those with adverse events. So here we had not the same pattern as with paroxetine, but this was not significant. But again, the important thing is here that we do see a difference also when excluding patients with side effects. So we do not agree with Kirsch at all. Kirsch also suggests that the extent of side effects is important, so that patients with a lot of side effects would have a better effect than patients with mild side effects. So here we have only included patients with side effects, separating those with mild adverse events, moderate adverse events, and severe adverse events. And there is absolutely no impact whatsoever on response. So we disagree also on this point. And this has been published in Molecular Psychiatry in 2018. Also, then we are now approaching the end of this presentation. And of course, you have all heard the rumor or the suggestion that SSRIs should be suicide-provoking to a very great extent, that a lot of patients that are not suicidal from start become suicidal by an SSRI. For example, advocated by Professor Healy from United Kingdom in this and other publication, Let Them Eat Prozac. We have studied the early side effects of SSRIs in 2 reports. This was not on suicide but on anxiety aggravation. We thought we should find an anxiety aggravation. As you know, in panic disorder patients, it's very common that they become worse with respect to anxiety early on in treatment. That is known by everyone treating panic patients. So how common is this phenomenon? We wanted impression, and we can detect it, but it's not that common. This is psychomotor agitation, and here in fact you have less symptoms in the actively treated group already after week 1. So psych anxiety, the same. We have more symptom reduction in those on active treatment already at week 1. But in somatic anxiety, we do in fact see a symptom aggravation in the SSRI group at week 1 that then fades away. So here we have some indications that we have an anxiety. We can have an anxiety provocation also in depressed patients, not only in panic disorder patients. Also, when we look on anxiety-related adverse events, in agitation, it's no a certain difference, but it's somewhat more common in the SSRI treatment, but this does not become significant. With respect to anxiety, it's somewhat more common in SSRI treated patients, again, not significant. Nervousness, it's twice as common in SSRI treated patients, and this is significant. And if we analyze any of these, we do have a certain difference. It's 10% of SSRI treated and 5% of placebo-treated patients that display more anxiety. So it's definitely so, and I don't think anyone would question that these drugs could cause some initial anxiety during treatment. But what about suicide? Suicidality, is that also increased early on? And this has been studied before us by Gibbons and co-workers, and they did this on patient level in a very elegant study showing that in fact they saw no such effect in subjects, older subjects. They saw, on the contrary, a beneficial effect of both fluoxetine and venlafaxine already after 2 weeks of treatment. In younger subjects, they saw no differences in one direction or the other. And we have just, one could say, replicated those findings. We have very similar findings, but with other drugs, paroxetine, citalopram, and sertraline. And here we in fact see a beneficial effect in those above the age of 25 already after 1 week of treatment. So if anything, of course, this is not the optimal population to study a suicidal reduction effect, because to be included in clinical trials, you shouldn't have too much of suicidality at baseline. But nevertheless, we do see a beneficial effect already after week 1, no signs of an aggravation. And just like Gibbons, we don't see any significant effects in the younger subjects here. I would definitely not claim that it couldn't happen in individual patients, that they do display in initial anxiety and perhaps also suicidality, and therefore obviously every SSRI prescription must be followed up carefully with phone contacts or visits and so on, definitely. But I would claim that the net impact is not, as I've argued, pro-suicidal but anti-suicidal. So also here we do not agree with the critics. I think I should stop here. In fact, to leave room for some questions, I would just like to, without showing the data, point out that we have replicated most of these findings that we have seen in the SSRI material, also in duloxetine trials. Very similar data, surprisingly similar data. If interested, you can find this paper, but I won't present these data now. But it's very much the same. What we, however, did not find was a different clinical profile between the SNRI and the SSRI. We thought perhaps that the SNRI would show signs of being more activating or so, because it has this noradrenergic component in the mechanism of action. But these are the relative effect on different symptoms in the Hamilton scale, and as you can see, they are very similar, duloxetine and the SSRIs. So my conclusions here would be that SSRIs and SNRIs display a robust dose-dependent reduction in depressed mood and other key symptoms of depression that is not due to side effects breaking the blind and not restricted to those with severe depression at baseline. The net influence on suicidal ideation is beneficial from week 1 and onwards. The widely propagated questioning of the effect and tolerability of these drugs may cause harm by prompting patients and doctors to refrain from the use of an effective and potentially life-saving treatment. So I'm not saying that SSRIs are ideal treatments, they are ideal drugs, they are certainly not, but they are not as bad as they are often painted. Thank you so much for your kind attention.
Thank you very much for this comprehensive presentation. Is there any question from the audience?
Thank you, Professor Eriksson. That was a masterful account, and I find myself agreeing with you completely in terms of your analysis. So if you forgive me, I want to ask you a question that's a little bit outside the envelope of the talk. I missed the very beginning of the talk because I had to chair another session, but in the current age, we are increasingly interested in real-world data and in effectiveness. And clinical trials, of course, deal with efficacy. And for generations, we've been dominated by central tendency analysis or group analysis for statistical comparisons. And now we're moving into a world where we look at multi-feature analysis with machine learning and so on. A few papers have emerged trying to look at predictors of antidepressant responses. I wonder if you could just comment on what you think about that area, since you have such a broad depth of knowledge in terms of clinical trials and efficacy. Do you think we can benefit more in terms of serving our patients by understanding responders and non-responders more effectively? Because the game of averages, you very eloquently explained why you have to be very careful about looking at the data, not jumping to false conclusions. The debate that you described has been particularly annoying for some people, and I think that your position is strong and enlightened. But I wonder what you think about effectiveness, the possibility for predictive analytics, and so on in the future.
Thank you very much, and I'm happy that we have the same stance on this. I would say two things. First, I think it's important to state, I mentioned some factors in the clinical trials as they are usually performed that markedly reduces the chance of detecting a difference between active drug and placebo. But I think it's also fair to state that on the other hand, these studies to some extent could yield a better outcome than real life because, for example, comorbidity is so much more common in real life and other factors and drug abuse, etc., and so on and so forth. So I really admit that is important. And I think there are problems with of course, we have the very famous STAR-D study that is always cited, and it's often cited as evidence that antidepressants are not very effective. I don't think that is fair. In fact, if you look into the data, for example, there is one study by Søren Dinesen that if you apply the Beck scale on the outcome in study, it's not that bad. Then I think it was somewhat unfortunate that they had citalopram as starting drug, because citalopram, if any SSRI is somewhat less effective than the others, it might be citalopram. It's shown as compared to escitalopram to be less effective, and so on. So there are some problems with that study, but it is an attempt to do a naturalistic study that I think is very commendable, and we must do more studies of that kind. I completely believe that, and so they are more close to the real world. Then I also believe that in the future we will have some kind of precision medicine here, and we are doing just what you are talking about, machine learning now. This Fredrik Hieronymus guy I mentioned is much into that. I couldn't say that we so far have identified any very strong predictors for responders here in responders on placebo, responders on active drug, and so on. But we and others absolutely are trying to do that, and I do think that in the future it will be possible to say that for this particular patient, this particular drug would be beneficial, and so on. And so I really believe in that. What is not evidence-based, but I hear from psychiatrists. I haven't worked myself as a psychiatrist for 40 years, and then I was very young, so I'm not a clinician, I'm a pharmacologist. But what I hear from experienced clinicians is that they already believe that there are such differences that are meaningful and can be used. For example, a lot of people tells me that bupropion might be preferable in patients that are energetic and a lot of tiredness and so on, while they would not use that drug for a more anxious patient. Just to take a simple example. I also think that some of the old MAO inhibitors would be very effective from some kind of atypical depression and so on. So I think already today we have some experience suggesting the importance of tailoring the treatment for specific patients, but it's so far not evidence-based. And I do think, just as you, that machine learning might be helpful in this area. Absolutely.
Thank you. We have finished our time, but I have one last question with short comment. What's your decision about the cognitive disturbances of depression? What is the efficacy of SSRIs over the cognitive disturbances in depressive patients?
Yeah, unfortunately, very few studies have very few scales address cognitive aspects. Difficulty in concentrating is one such that sometimes appear in, but most scales do not comprise that. Very seldom one has done cognitive testing. I think these are very important issues. I think so far it's not too much to say about it. The relatively novel antidepressant from Lundbeck called vortexetin, Brintellix is a trade name. They have a somewhat peculiar pharmacological profile. So they have, for example, an increase in both dopamine and acetylcholine in the extracellular, not only of serotonin. It's a serotonin uptake inhibitor, but also does other things so that it elevates acetylcholine and dopamine. And they claim that they have a better effect on cognitive symptoms as compared to other SSRIs. And I've looked into those data, and I think it's I'm not totally convinced, but I think it's quite promising. So, and to my knowledge, this is the only company so far that have really tested their drug from that perspective. But I certainly agree that one should not ignore this aspect in the depressive symptom. It's definitely an important aspect, and I think much more has to be done on that. Also, for example, now that people are starting to use ketamine or esketamine for treating depression, and reasonable question is if it could in some way impair cognitive function because it blocks NMDA receptors that are important for cognition. I have heard Jon Christel giving lectures that it does not seem to be the case so far, at least, but I totally agree with you that this is an aspect that must be studied further for all novel antidepressants and preferably also the old ones.
Okay, thank you very much again, and maybe see you next year.
I would like that. Thank you so much.